What is pulmonary embolism? Pulmonary embolism is a thrombus or embolus lodging into the pulmonary artery leading to the cutoff of blood supply to the lung. So this is a serious life-threatening condition. So this is the definition of pulmonary embolism. What are the causes of pulmonary embolism? Most common cause is the thrombus, most commonly from the DVT. Another is the fat embolus, air embolus, and the amniotic fluid embolus in pregnancy. So these are the most common causes of pulmonary embolism. Thrombus is the most common cause among the given causes. What are the symptoms of pulmonary embolism? So most common is the sudden shortness of breath, pleuritic chest pain, tachycardia, cough, and hemoptysis. Why imaging is important in pulmonary embolism? So pulmonary embolism present with the vague symptoms and symptoms are non-specific. So imaging plays a central role in confirmation of diagnosis, localization of thrombus, assessing severity and complication like right heart strain. Imaging modalities used for the diagnosis of pulmonary embolism are the CT pulmonary angiogram. It is the investigation of choice and it is the gold standard. Whereas the echocardiography done in unstable patients. Ventilation perfusion scan is done in the patients contraindicated for CTPA. Chest X-ray is done to rule out the other causes of symptoms, and USG Doppler of lower limb done to rule out the DVT. CTPA or CT pulmonary angiogram is gold standard investigation in the suspected pulmonary embolism and it is most commonly used. So it is the investigation of choice. By CT pulmonary angiogram, direct visualization of clot as a filling defect can be seen in the pulmonary arteries. It is very high sensitive and specific and it shows the rapid detection of the intrapulmonary arterial thrombus and it allows the assessment of main, lobar, segmental and subsegmental arteries, and it also shows the clot burden and right heart strain. Now the direct CT signs of pulmonary embolism. These are the first one is the intraluminal filling defect, that as we can see in these images, the intraluminal filling defects or hypodensity within the arterial lumen. Polo means sign. On the short axis of the artery, we can see as the central filling defect or hypodensity. So this is the central hypodensity and this is the artery lumen. Peripheral is the contrast. We can see as the hyperdense area and this is the clot. So this forms the polo mean sign. Another one is the railway track sign. So this is seen in the long axis of the pulmonary artery. As we can see that this is the long axis of the pulmonary artery and this is the filling defect simulating as the railway track. So this is called the railway track sign of pulmonary embolism. Saddle thrombus, that is the thrombus within the bifurcation of the main pulmonary artery. As we can see in this image, this is the saddle thrombus. So these are the direct sign of pulmonary embolism. Now the indirect CT signs of pulmonary embolism. So indirect signs help assess the severity and complication of pulmonary embolism. So we can see that the pulmonary infarct is the indirect sign, which we can see as the, this is the soft tissue density area or hyperdense area in the right lung field seen in the axial section of CT image, whereas in this right lower zone shows the a triangular radio opacity in right lower zone. So this is the chest X-ray image. Pleural effusion, here we can see that the minimal pleural effusion on right side of lung and the right ventricular left ventricular ratio which should be less than 1, but In case of pulmonary embolism, it is more than 1, suggesting the pulmonary hypertension. And it is seen in the acute pulmonary embolism. As we can see in this image, this blue line is the right ventricle diameter, whereas the red one is the left ventricle, and its ratio is more than 1. Now the ventilation perfusion scan. So it is described as the area in the lung where the air or ventilation is normal and the blood flow or perfusion is blocked or abnormal. So this is the ventilation perfusion scan. Now when to do this? Ventilation perfusion is done in the patient who are contraindicated for the CT pulmonary angiogram, such as the pregnancy, contrast allergy, and renal failure. Now ventilation perfusion lung scanning done by the ventilation is done by the technetium-99m labeled agents like carbon or aerosolized DTPA or radioactive xenon inhalation. So these radioactive substance deposit on the bronchoalveolar wall, and they shows the area of ventilated lung. Whereas the for perfusion, technetium-99m level microaggregated albumin is injected into the vein and it aggregated on the precapillary arterioles. For ventilation, radioactive substance deposit on the bronchoalveolar wall, whereas in perfusion, they deposit in the precapillary arterioles and they denote the area of perfused lung. Abnormal perfusion scan excludes pulmonary embolism but is found in a minority, that is the about 25% of patients. Perfusion defects are non-specific with only about 1/3 of patients with defects having pulmonary embolism. Now the mismatched perfusion defects that are segmental or large are termed high probability defects. So segmental or large defects are termed high probability defects. A single mismatched defect is associated with a prevalence of pulmonary embolism of about 80%, whereas this prevalence is more than 90% with 3 or more defects. We can see in this image, this is the ventilation perfusion map. We can see that there is a blue arrow denoting the perfusion defect in this image. So this is the ventilation perfusion mismatch. Now this is the image showing the first one is the ventilation map perfusion. There is a defect, and when two are combined, then we can clearly see that there is a ventilation perfusion mismatch. This is the ventilation perfusion mismatch. Chest X-ray is the initial test and it is most commonly done. It is often normal in pulmonary embolism, rule out other causes of pulmonary symptoms, and it is not diagnostic. Classic chest X-ray findings are the knuckle sign, that is the abrupt tapering or cut off of the pulmonary artery. As we can see here, this is the knuckle sign. Pala sign is the enlarged right descending pulmonary artery. So sign related to the right descending artery is a Pala sign, that is the enlargement. Hampton Hum sign, that is the dome shaped pleura based opacification due to the lung infarct. So this is the triangular area of radio opacity is the Hampton Hum sign. Pleural effusion, that is the blunting of the bilateral CP angle. Westermarck sign is the focal peripheral hyperlucency secondary to the oligemia. So this is the due to the oligemia. Flesner sign, that is the prominent central pulmonary artery, and Chang sign, that is the enlargement and sudden alteration in the diameter of pulmonary artery. Knuckle sign, Pala sign, Flesner sign, and Chang sign are the features related to the pulmonary artery. So this is the Flesner sign, which is the enlargement of the central pulmonary artery, and this is the descending artery, right descending pulmonary artery enlargement. So this is called the Pala sign, and this is the triangular or dome shaped opacity in right lower zone. So this is the Hampton Hum sign, and the lucency in the lung field due to the oligemia is Westermarck sign. So these are the signs of pulmonary embolism in chest X-ray. So what are the findings of pulmonary embolism in echocardiography? So thrombus is not directly visualized in echocardiography, but other ancillary findings that is supporting the acute pulmonary embolism can be seen in echocardiography, like sinus tachycardia, right ventricular dilatation, and McConnell sign. So what is the McConnell sign? It is the akinesia of the right ventricular wall. So this is the akinesia. So this is seen in the mid-free wall of the right ventricle with preserved contractility at the apex. So this is the preserved contractility at the apex can be seen, and this does not show the contractility in the mid-free wall. So this is called the McConnell sign in echocardiography. Other imaging modalities used for the pulmonary embolism are the lower limb Doppler for the screening of deep vein thrombosis and pulmonary angiogram, that is the DSA. So this is done only for the intervention or removal of thrombus. Imaging based risk stratification is done by classifying pulmonary embolism severity, which directly affects the management and prognosis. Whereas the massive pulmonary embolism causes the hemodynamic collapse and it requires urgent reperfusion. Whereas the submassive pulmonary embolism shows right heart strain like elevated troponin BNP and right ventricular dilatation, but with the normal blood pressure. In massive there is hemodynamic collapse, and in submassive there is a normal blood pressure, indicating high risk but stable hemodynamics. So there is stable hemodynamics. Now by imaging, when to say massive pulmonary embolism or high risk. So in CT pulmonary angiogram, there is a large central thrombus. So as we can see, there is a saddle thrombus. This is the large central thrombus causing the occlusion of the pulmonary artery, and there is a increased right ventricle to left ventricle ratio, that is more than 1, and intraventricular septal bowing. We can see here is the bowing of the intraventricular septum. So this is also the indicator of the massive pulmonary embolism, and contrast reflux into the IVC and hepatic veins. These are the indicator of the massive pulmonary embolism. In echocardiography, there is no direct visualization of the thrombus, but there is severe right ventricular dilatation, McConnell sign, that is the free wall of right ventricle shows no contraction, whereas the apical region shows contraction. So this is better appreciated in echocardiogram, and reduced right ventricular systolic function. So in echo we see that the severe right ventricular dilatation, McConnell sign, and reduced right ventricular systolic function. Submassive or intermediate risk pulmonary embolism. Key features are the hemodynamically stable but right ventricular dysfunction. There is segmental or central pulmonary embolism. Right ventricular to left ventricular ratio is more than 1. Septal flattening. In massive there is septal bowing, but in this there is septal flattening, as we can see here, septal flattening, and right ventricular to left ventricular ratio is also increased, as we can see in this image. And pulmonary artery enlargement in CT can be appreciated. So this is the pulmonary artery and this is the aorta. So aorta to pulmonary artery ratio should be less than 1, but in this case more than 1. So this identifies the patient at risk of deterioration. In echocardiography, there is moderate right ventricular dysfunction and raised pulmonary artery pressure is seen in submassive pulmonary embolism. Low risk pulmonary embolism. So in this, there is a small segmental or subsegmental emboli with normal right ventricular left ventricular ratio less than 1. No septal bowing is seen, and echo also shows the normal right ventricular function. So we can see in this image there is a small thrombus in the segmental artery. So its imaging role is to support the conservative management. Now the rapid revision table of the pulmonary embolism. So CT pulmonary angiogram is the gold standard for the diagnosis of pulmonary embolism and right ventricular strain. Ventilation perfusion scan is the alternative when CT pulmonary angiogram is contraindicated. Echocardiography is done for the risk stratification in unstable patients. Chest X-ray is done to exclude the other causes of pulmonary pathology or for the baseline investigation. Pulmonary angiogram is rarely done and it is done for the interventional planning. So remember, CT pulmonary angiography is the investigation of choice for diagnosing pulmonary embolism, whereas the VQ scan is the alternative for the CTPA. These are my references, and thank you for watching. Like, share and subscribe for more radiology videos.